Hello and welcome to your cardiovascular medications lecture. This is going to be part one of your cardiovascular medications. So the first grouping of medications are going to be those that are affecting urinary output, and this is going to be from chapter 19 in your ATI pharmacology textbook. So I've created this slide as kind of a generalization. So for diuretics, in general, most of these are going to have the same concerns and then therefore the same nursing interventions. So if you're pulling fluid off, that's what diuretics do. They're going to act in a different way, but essentially it's to get fluid out by peeing it out. So if you're peeing out excessive fluid, we can have dehydration. So we're going to need to monitor their hydration status, their intake, and their output. So if a client has any symptoms of dry mouth and increased thirst or have decreased urinary output, then that client is dehydrated, or you should definitely be concerned for dehydration if you in the near future, especially vital signs wise. So decreased urinary output. So if someone is peeing less than 30 milliliters in an hour, then they have a decreased urinary output. So if they have a Foley catheter, then of course you can assess every hour, 30 milliliters or more. 30 milliliters or more, then they're good. If they're urinating in a urinal, that's great. But if they're just going to the bathroom, you need to know. If they're on diuretics, you need to know what they're putting out. So they need a urinal or what's called a hat in their toilet. So it's going to catch that amount of urine and then we can measure it. And then, so how long has it been since their last episode of urination? So if it's been 3 hours and they pee 300, then they have now urinated an average of 100 milliliters per hour. So they are doing fine. They don't have a decreased urinary output. We expect from a diuretic to increase urinary output, but a decrease can occur if they are dehydrated. So we need to be mindful of this number, 30 per hour. Another thing that can happen is the electrolyte imbalance. So if all of this fluid is going out, sodium, potassium are your big things that also follow water. Sodium and potassium. So sodium and potassium are also your major electrolytes that are attributed with muscle contraction. And the main muscle, the first one that is going to be noted for symptoms of changing in these electrolyte imbalances is going to be heart. And so cardiac monitoring, so like for arrhythmias, dysrhythmias, is what we're going to be looking for, the cardiac monitor. Third thing, fluid coming out, hypotension. So that is a low blood pressure. So we're going to need to monitor their blood pressure, of course. Education about changing position slowly, which remember is called postural hypotension. And then lastly, kidney damage. The kidneys are on overdrive trying to filter all of this and put more fluid out into the bladder and therefore pee it out. So the kidneys are on overtime and eventually they can get tired, if you think of it this way. So monitoring their kidney function to make sure that their BUN and creatinine and urine osmolality are appropriate. BUN and creatinine, if they start increasing, then there can be some kidney injury. You can have an acute kidney injury from diuretic use. So be mindful of watching their kidney function tests. Also with their intake and output, we're going to be doing some of this in lab for calculating all of their intake, calculating all of their output, and comparing it. So is there a deficit or an overload? So are they retaining fluid? or is there a deficit, as in they're dehydrated, they're retaining it. If there is excess coming out than what's going in, they're going to be dehydrated, right? Also with kidney damage, if they start increasing weight or signs of fluid retention, like dependent edema, pitting edema, crackles in the lungs, things like that. These are all signs that there's fluid being retained in the circulatory system or extravascular system. And so if they're supposed to be on daily weights, they need daily morning weights, same time every day. So if they have increased in 2 kilos in a day, then they have gained 4.4 pounds of fluid, which is 4.5 liters, equivalent to 4.5 liters of fluid that they're on their body. Can be a lot. So, getting into the specifics of diuretics, high ceiling loop diuretics, such as furosemide, it's going to work in the loop of the Henle to block reabsorption of sodium and chloride and prevent the reabsorption of water, causing diuresis. So it's going to cause diuresis. In addition to those common symptoms on the previous slide, these ones are specific to loop diuretics: ototoxicity, hypokalemia, and hyperglycemia. I've given you a little mnemonic here for potassium deficit, which is hypokalemia. So it talks about weakness, arrhythmias, lethargy, 30 pulse. You remember potassium is one of the major ones for your cardiac contraction. So monitoring your cardiac status, making sure your potassium level is in normal ranges. So hypokalemia is seen as less than 3.5. It should be 3.5 to about 5, and this will change slightly based on hospital facilities, but 3.5 is pretty standard for the low end. So if it's less than 3.5, hypokalemia. So then you're going to look for nausea and vomiting, weakness, fatigue, and leg cramps, because remember, contractility muscles. So leg cramping. We're going to encourage our clients to consume foods high in potassium, such as bananas, potatoes, dried fruits, nuts, spinach, and citrus fruit. However, we're going to make sure that they avoid licorice, because this can increase hypokalemic effects. And then hyperglycemia is an elevated blood glucose level. So with high ceiling loop diuretics, they can also have hyperglycemia. Thiazide diuretics, such as HCTZ, HYDROCHLOROTHIAZIDE is the example here. These are going to work in the early distal convoluted tubule to block reabsorption, again, of sodium and chloride, preventing the reabsorption of water, thus promoting diuresis. This can have hypokalemia and hypochloremia. So again, your cardiac status, your symptoms, consuming foods, and avoiding licorice. Hyperglycemia again, but then you also have hypertension, so high blood pressure. This is especially so if a client is also taking ginkgo biloba. This is an over-the-counter supplement herb. People like to take that usually have cardiac issues, but with HCTZ, ginkgo biloba can lead to hypertension. So we need to be mindful of what other medications these clients are taking in order to tell these clients they need to stop taking this ginkgo. Potassium-sparing diuretics such as spironolactone. These block the action of aldosterone, which is produced by the adrenal gland on the kidney. This causes sodium and water retention, resulting in potassium retention and the excretion of sodium and water, which is diuresing. So here is the opposite of potassium. It's hyperkalemia. So these are going to be levels that are above 5. So greater than 5 is hyperkalemia. And this is even going to be more so if someone is taking potassium supplements. They should not be taking potassium supplement with spironolactone. Okay? So then here's your symptoms. A low blood pressure, drowsiness, diarrhea, abdominal cramping, oliguria. Oliguria is very little urine output. And then endocrine effects can also happen with spironolactone. So there you get your was it growth hormone? Stimulating hormone? You get your deep voice, impotence, gynecomastia, and irregular menstrual cycle. So like your sex hormones. And then your metabolic acidosis can also happen with spironolactone due to blocking the aldosterone. And so drowsiness and restlessness can happen with spironolactone. So monitoring activities that require alertness, and then once they are more used to the medication, maybe it would be better, but definitely don't take the first dose right before they have to go drive their vehicle. Osmotic diuretics, again, in addition to the previous first slide, we now have specific ones. So heart failure and pulmonary edema. So this is going to be dyspnea, weakness, fatigue, distended neck veins, weight gain. So remember your left heart failure, right heart failure. This is essentially what can be happening with osmotic diuretics, because this is going to pull the fluid back into the vascular and extravascular spaces. And so it's fluid shifting. So if the fluid is in my dependent edemic legs, using mannitol, yes, pulls it back into it, but can be quite overwhelming, especially if it's done quickly in a short period of time for the circulatory system. So then you have your symptoms of your left and right sided heart failure. It's not causing heart failure necessarily, but it can if it's not fixed. Does that make sense? So it's causing these symptoms due to the excess fluid volume. And then when the fluid volume is excess to the heart, when it gets excess to the heart, that's when it can become heart failure, when the cardiomegaly develops and becomes overwhelming for the heart to maintain its normal contractility and livelihood. What can also happen is rebound increased intracranial pressure. And so if they have a level of consciousness change, they have a change in pupils, headache, nausea, or vomiting, we need to be very concerned. We need to avoid taking this for clients that have a history of an intracranial injury, so that this does not happen. Also, metabolic acidosis can occur, so we're going to be monitoring their lab values and look for drowsiness or restlessness. So neuro, or your mannitol. The next section here are going to be medications affecting blood pressure from chapter 20. The commonalities between antihypertensive are going to include your first dose hypotension. So after they take their first dose of medication, they have a drop in blood pressure. Orthostatic hypotension, blood pressure dropping upon moving, changing of positions. And then dizziness and lightheadedness. So be mindful of those. Our first set of medications affecting blood pressures are going to be your angiotensin-converting enzyme inhibitors, also known as ACE inhibitors. These are going to be medications that end in pril, like captopril, lisinopril. So these are going to reduce the production of angiotensin 2 by blocking the conversion to angiotensin 1 to 2 and increasing levels of bradykinin, leading to vasodilation in the arterioles, excretion of sodium and water, retention of potassium, and reduction in changes to vessels and heart related to angiotensin 2 and aldosterone. Essentially, what it's saying is just what this picture is saying. A normal blood vessel with then an ACE inhibitor becomes a relaxed vessel. So not necessarily vasodilation, but relaxation. So it expands, it opens up, which then of course lowers the pressure on the lumen, therefore lowering your blood pressure. However, dry cough is a bad sign. As soon as a client starts having a dry cough, they need to stop taking this medication. This can lead to angioedema, or angioedema can start on its own. Angioedema is going to be swelling of the tongue or oral pharynx, so facial edema. We're going to need epinephrine, and we need to conserve their airway, so we may need to intubate them. And then now we need to consider this as an allergy. The other thing that can occur with ACE inhibitors is hyperkalemia. So monitoring for numbness, tingling, and make sure that we're avoiding salt substitutes and supplements of potassium, because salt substitutes for someone that's trying to avoid salt because of heart failure, kidney failure, whatever, they're trying to not retain fluid, they may change to a salt substitute. Often salt substitutes contain potassium. So we need to be mindful and educate clients about this so that they don't end up with hyperkalemia in the near future. So here are some little mnemonics, again, about your hyperkalemia and then ACE inhibitors. Angiotensin 2 receptor blockers are also called ARBS. These are going to end in the SARTAN. So losartan, valsartan are your examples. These block angiotensin 2, resulting in vasodilation in arterioles and in the veins, and therefore also excretion of sodium and water. So angioedema can also occur with ARBS, and also fetal injury. So we need to make sure that clients that are of reproductive age or potential that they are using a contraceptive if they are on an ARB. Aldosterone antagonists, such as spironolactone, are going to reduce the blood volume by blocking aldosterone receptors in the kidney, promoting excretion of sodium and water and retention of potassium. So this may cause hyperkalemia and hyponatremia. So watching those salt substitutes, monitoring for paresthesia and tingling, and don't take this medication with grapefruit juice because this can worsen these effects. Spironolactone can also cause flu-like symptoms, such as fatigue, headache, diarrhea, abdominal pain, and cough. These usually resolve over time. Endocrine, gynecomastia, menstrual irregularities, and impotence are also potential complications for spironolactone. Should be reported to the doctor and stop taking the medication. Here are your mnemonics again for hyperkalemia, and then for your adrenergic antagonist blockers, which adrenergic is the old term for your angiotensin. Okay. Calcium channel blockers. Indapine for most of them, like amlodipine. But then also you get these two extra ones for verapamil and diltiazem. These are going to block calcium channels. That's calcium channel blocker, leading to vasodilation of the smooth muscles in the peripheral arterioles and the arteries and arterioles of the heart. So the pines are going to have different effects than the verapamil and diltiazem. Well, they have the same effect on the blood vessels. They have different side effects, I should say. So the pines, watching for reflex tachycardia. So taking this medication causes them to have tachycardia. And if that occurs, then we need to be mindful that we might need to add a beta blocker to their profile. Beta blockers we'll get into in the next lecture is an antiarrhythmic, so it can bring that heart rate down. And acute toxicity can also happen with amlodipine, so monitoring again their vital signs and their cardiac rhythm. Administering norepinephrine. That's a new medicine that we'll learn also shortly. Calcium, lidocaine, and IV fluids. All of these things are necessary to treat acute toxicity of calcium channel blockers. And then a cardioversion or a pacemaker or a temporary pacer may also be necessary until the calcium channels are no longer being blocked, because you need calcium to contract. So we may have to stimulate the heart by pacing it, or cardiovert, which will deplete the electrolytes and make it restart over and actually accept the calcium again. So it's like shock delivery. Peripheral edema also can happen. So monitoring your blood pressure, watching for the edema showing up in the peripheral vascular systems, pitting edema. Daily weights are going to be necessary. And we may need to administer a diuretic if we start to see peripheral edema occur to get that fluid off of their extremities. Now with verapamil and diltiazem, they may have bradycardia. So it's the opposite effect, but we're still monitoring their heart rate, their rhythm, activity and tolerance. But if this starts to happen, we're not giving them another medicine. We're going to stop, because if bradycardia slows down the heart enough, like we talked about in your foundations class, can lead to heart failure. Dysrhythmias, so widening of that QRS and the QT intervals. That interval has to be a certain amount of time. If it takes too long for something to contract or too long for it to relax, can interfere with the rhythm, right? So it can cause dysrhythmias. Toxicity, in this instance, is going to be a little bit different as well. So hypotension, bradycardia, AV block, which is a type of dysrhythmia, and ventricular tachydysrhythmias. But essentially, as you can see, we're treating it very similarly. Norepi, calcium, lidocaine, and fluids, cardioversion or pacer, because it's the same thing that's going on, because it's affecting the heart the same way. Remember, before you can administer a calcium channel blocker, the client's heart rate must be greater than 50 beats per minute and have a systolic blood pressure greater than 90 to administer your medication. Centrally acting alpha-2 agonists such as clonidine and METHYLDOPA. These act in the CNS to decrease sympathetic outflow, resulting in decreased stimulation of the adrenergic receptors of the heart and peripheral vascular system, resulting in bradycardia, decreased cardiac output, vasodilation, and a decreased blood pressure. which is what we're doing it for. These can cause drowsiness and sedation, though. Initially, they usually diminish with continued use. So this is a very common medication that we'll give in the emergency room. Someone comes in with severe hypertension, and we'll give them some clonidine. If it's not like, now if it's like super high, then of course we're giving them an IV medicine. But if it's, I don't want to give you a specific number and then you only use it for those situations, but if it's significantly high, we're going to try the least invasive possible, right? Now, if there's no emergent signs that, if it's emergency hypertension, then yes, we need to get it down as soon as possible so that we don't have a stroke. But if it's in that moderate range where it's hypertension, but it's not like stroke level hypertension, then we'll give them some clonidine. It usually comes in like 0.1, 0.2, 0.3 milligrams, and usually in like 30-45 minutes you come and recheck it and that blood pressure has dropped. That's what our goal was. But again, that first dose, hypotension, so say it was 160 systolic and you come in there and it's 140 and you're like, great, we're getting better. It did just drop 20 points. So you still need to monitor your client though for their symptoms, because that change can be quite drastic. But hopefully the symptoms that they had with their high blood pressure are being resolved and they're not having new symptoms is the key. But you need to continue checking on them. If that blood pressure keeps dropping, then of course you have a problem. We like clonidine in the emergency room. Why I'm telling you the story is because it acts pretty quickly, and it acts not just rapidly, but effectively. It is an effective antihypertensive, but you still need to be mindful of it. Usually if we're giving this to clients for those reasons, it's only like 1, maybe 2 doses. If a client you see that has clonidine on their medication profile, they take this on a regular basis, then you should have an alert going on in your brain. This person has severe high blood pressure and requires this medication. And so if they're in the hospital and their blood pressure is creeping up and they don't have their clonidine, you need to get them their clonidine. This is one of those medications, not only because it affects their blood pressure that they need, but you have to taper off of this medication. If you don't taper off of this medication, then they can have even more severe high blood pressure than the reason that they were taking it in the first place. And in order to be on this medication, you have to be really high blood pressure in the first place. So then they could stroke out because you aren't paying attention to their initial medication profile and know that they need clonidine. So they need to taper off very slowly off this medication. Don't just not acknowledge this. Also, dry mouth can happen. This is not the same thing as dry cough. This is dry mouth. But this again usually resolves in about 2 to 4 weeks. But so giving them examples of how to deal with this over the next few weeks, because yes, it is bothersome to have a dry mouth all the time, but it will resolve. So they can chew on some gum, suck on a hard candy, or a small amount of water or ice chips, if that's allowed for their fluid hygiene. If they're on fluid restrictions, then maybe not, but they can do the other things. And usually candies are sugar-free candies. It's a good rule of thumb. Beta adrenergic blockers are also beta blockers. These are going to end in lol. So metoprolol, propranolol, things like that. These are going to block the myocardium electrical conduction system of the heart, resulting in a decreased heart rate. So this is also an antiarrhythmic, but it's also going to block, therefore causes the vasodilation, therefore causing a decreased blood pressure. So what we're going to monitor though for, because it's interfering with the heart rate to get there, watching for bradycardia. So monitoring their heart rate, and don't give it to them if their if their heart rate's less than 50. If their I keep trying to say blood pressure. If their heart rate is less than 50 and you give them a beta blocker and it slows down their heart rate even more, you're gonna possibly stop their heart. So don't do that. Decreased cardiac output also can happen, so caution in clients that already have heart failure. Monitoring for their shortness of breath, signs of edema, weight gain, fatigue, all those heart failure symptoms. Because if it's not getting out cardiac output, then it's retaining in the heart, right? And fluid retaining in the heart is heart failure. AV block, which is already a dysrhythmia, monitoring their heart rate. If rebound excitation can happen if we don't taper off. So again, here's that same picture, tapering, don't stop abruptly for these medications also. You can have rebound myocardium excitation, meaning an excess of excitation, meaning an increased in triggering, therefore an increase in arrhythmias, because if it's not necessarily tachycardia, it can be tachycardia if it's being triggered a sinus rhythm more frequently, but if it's not triggering a normal rhythm, it can be an arrhythmia. So if it's not tapered over time. Also, bronchoconstriction can happen with these medications, so avoiding with clients that have asthma. And then your glycogenolysis. Oh goodness, glycogenolysis. So this is the breakdown of glucose to make or glycogen to make glucose. And so caution with clients that have diabetes, of course, are going to be for these clients. So beta blockers, BBBB, beta blockers, BB, bradycardia, bronchoconstriction, and then your dysrhythmias, because it's also an antiarrhythmic, okay? BBBBD. Here is your mnemonics for your beta blockers. So there's the difference between a beta 1 versus a beta 2 blocker. Beta 1s affect the heart and beta 2s affect the lungs. And then another one about your beta blockers for your OLALs or LALs. Hypertensive crisis. This is that severe hypertension that I was talking about. Hypertensive crisis means it's an emergency. So examples here are going to be nitroprusside, nitroglycerin, nicardipine, clevidipine, and enlanoprat, and esmolol. These are all different types of different classifications, but they directly cause vasodilation to the arteries and veins rapidly. So if they have such severe hypertension, then we need to rapidly decrease it before problems happen. So excessive hypotension, of course, can happen. Cyanide poisoning, so headache, drowsiness, cardiac arrest. We're gonna, of course, do CPR if they get to the point of cardiac arrest. But if we start noticing these symptoms, we need to reverse with thiosulfate. So that is your antidote. these medications, we're going to be cautious in clients that have liver dysfunction. We want to try and make sure that they're not having to be on this for a long period of time. We need to figure out why their blood pressure is high. If we can get to the cause, then they can come off this medication. So we don't want them to really be on it for more than 3 days. We don't want their body to be dependent on this medication. And then also watching their cardiac rhythm, bradycardia, tachycardia, and then dysrhythmias on the EKG. All right, this last section is going to cover cardiac glycosides, which are going to be used in the treatment of heart failure. Chapter 21, I believe. So cardiac glycosides, such as digoxin, is going to cause a positive inotropic effect that increases force of contraction, and a negative chronotropic effect that decreases heart rate. So it increases contraction, the contractibility, and decreases the heart rate, which allows the blood to fill more in between those contractions, which increases stroke volume and increasing cardiac output, which is what we want for clients that have heart failure, right? It's not pumping effectively, everything's building up. So we want something to give them that will cause it to pump better and produce better cardiac output, right? However, dysrhythmias and cardiotoxicity can occur with digoxin, cardiac glycosides. And so here's your little mnemonic thing, picture thing about your toxicity levels. So digoxin, you're going to make sure that it's less than 2. 2 is your numbers here. So 2, 2, and 20. So you got all your 2s there to remember all your toxicity levels, because all 3, well, digoxin and theophylline are on this next exam. Lithium will be until exam 3, but you got your 2s there, okay? So, and then your picture down here on the bottom is an example of your dysrhythmias. So related to hypokalemia as a result, and then they get nausea and vomiting, generalized weakness. We want to ask them to consume foods that are high in potassium. We're going to monitor their heart rate and their EKG and potentially put them on supplements. So these people need potassium. If they have low potassium, this can cause these dysrhythmias, of course, and increase their likelihood for cardiotoxicity. Okay. GI effects can also occur, the anorexia, nausea, vomiting, abdominal pain. But then again, here you need to determine, is this something that is okay, or is this cardiotoxicity? And how do you determine that? By drawing their labs. So we would draw a digoxin level. So then they will test how much serum blood volume of digoxin is still circulating, and it shouldn't be no more than 2. CNS effects can also occur, such as fatigue, weakness, and vision changes. Again, fatigue and weakness, kind of similar to your cardiotoxicity. So rolling out your 2.0. And then if they get these vision changes, sometimes this is all people get, the blurry yellow or green or white halo around objects. Kind of like all of a sudden they have an astigmatism, but it can be this yellow-green color instead of white reflection band. This can often be unreported because they're like, oh, it's my eye, it's my eye, it's my eyes, and not think it's their medicine. So this is one of those things that, especially giving education beforehand, or when a new prescription is being given for digoxin, so that they monitor for this and they report it immediately. This is also one of those things that will be stopping the medication. Adrenergic agonists. such as epinephrine, dopamine, dobutamine, norepinephrine, remember norepi, ephedrine, and albuterol. These are going to activate alpha-1 receptors, leading to vasoconstriction of the skin, viscera, and mucous membranes, and mydriasis, which is dilation of the pupils. Beta-1 receptors activated, leading to an increased heart rate, increased contractility, and increased conduction rate, improving the performance of the heart, and beta receptors leading to vasodilation in the heart, lungs, and skeletal muscles. It's a lot. It's a lot. But the main thing is that it's going to lead to vasoconstriction and an increased heart rate. That is our expectation. We're giving this because we want to constrict and increase their heart rate, because they either have a very low heart rate or they have a very low blood pressure. So by causing the vasoconstriction, we're increasing their blood pressure. So these are the opposites of your antihypertensives. We want to have high blood pressure now because they had low when we're giving it to them. So what can happen though, because we're trying to increase their blood pressure, hypertensive crisis. So this can lead to cerebral hemorrhage. So we need monitoring that blood pressure very closely, which of course we should be, because usually these medications are on a continuous drip. So we're going to be monitoring their blood pressure every 15 minutes, every 30 minutes, sometimes even every 5, and titrating that medication on the IV pump to the desired effect to obtain a normal blood pressure. Cardiac complications can occur with increasing their workload, which therefore increases in oxygen demand, leading to angina, chest pain. So monitoring their urinary output, their heart rate, their EKG, and for chest pain. And then of course, necrosis. If we're causing vasoconstriction, and especially if we're using a peripheral IV, it's going to cause vasoconstriction to the vessels directly where it's entering, right? So necrosis can happen, extravasation, and we're going to need to administer a medication to cause, to counteract that vasoconstriction. So here is your, not really an antidote, but an intervention here to try and promote your blood flow back to the extremity. And this is the reason also that if these medications are going to be more than just a short dose, they're going to need a central line so that it doesn't have as devastating effects of vasoconstriction to those large vessels, whereas vasoconstriction to these small vessels can occlude it and therefore no longer being perfused. Okay, the last section here are going to be the anti-lipemic agents. So lipemic being the fat, so cholesterol. So trying to bring down the cholesterol. When we bring down the cholesterol, we're talking about the LDL. This is the bad cholesterol. So we want the LDL to be low. And then the HDL is the good one. We want the HDL to be high. H for high, L for low. That's what we want it to be. That is our ideal. So our LDL, we want below 130. And then HDL above 35 are our goals. The common concerns for anti-lipemic agents are going to be related to your liver and muscles. So hepatotoxicity is going to increase the AST, which is a liver enzyme. It's going to ensure a baseline. We need to ensure a baseline level liver enzymes are obtained prior to starting therapy, and then after 12 weeks of being on these medications, we need to check the liver enzymes a second time, and then routinely about every 6 months. If this liver enzyme becomes elevated, then we need to probably take them off of it, monitoring for signs for liver failure, liver disease, such as anorexia, nausea and vomiting, and jaundice. And of course, avoid alcohol, because this also issues with the liver. Myopathy being the muscles, you get the muscle aches, pain, tenderness, and can progress to the rhabdomyolysis. So this is the cells, the muscle cells being broken down and getting injuring the kidneys. And so we need to monitor CK levels. CK is going to be an enzyme released with muscle breakdown. And so when we're monitoring based off of our baseline and then throughout the therapy as well, the CK level. Statins, these are the HMG-COA reductase inhibitors. The statins, these are going to decrease LDL, increase HDL, promote vasodilation, decrease plaque inflammation and thromboembolism, and the risk for atrial fibrillation. This is how it works. There were no additional concerns here because there's nothing specific to this that's not on the general slide. Same here. Nothing specific to it, but ezetimibe is a cholesterol absorption inhibitor. This acts on the cholesterol secreted in the bile and absorption of cholesterol from food, resulting in lowering the LDL and the total. Fibrates, such as fenofibrate, is going to decrease triglyceride levels and increase the HDL by promoting production of the precursors to HDL. That's resulting in more HDL, which is what we want, high. But specific to fibrates can cause GI distress, which is usually mild and self-limiting and can be overcome over time. And then gallstones. Gallstones is a unique pain that causes them to have right upper quadrant pain. It can also radiate to the right shoulder. This is can also have symptoms of fat intolerance. So if they eat really fatty meal, oily meal, they'll have bloating, gas, pain. That right upper quadrant pain is triggered shortly after they have eaten one of those high-fat meals. And it's usually gallstones in the gallbladder or in the duct, occluding the gallbladder from functioning. And then here are your references for your ATI textbook from chapters 19, 20, 21, and then 24. Thank you.